Hi, I'm Zoe. I'm Dr. Franklin's virtual teaching assistant. He wanted me to cover information on integrating the insight stage skills, so that's what I will do here. Please feel free to pull up the PowerPoint slides he posted in the Blackboard classroom and follow along. I will be referencing the case study information he provided in class. I will also be prompting you to go to certain slides in the PowerPoint he has provided online. He would like you to use this presentation and the PowerPoint together to understand not only information provided in the chapter, but additional information on case conceptualization and treatment plans he thinks it's important for you to know as future clinicians. So now that Dr. Franklin has talked about some of the main insight stage skills, challenges, interpretations, disclosure, and immediacy, I would now like to transition to a discussion on how to integrate those skills. In this presentation, I will walk you through the overarching framework for integrating insight skills, as well as we will discuss steps to using insight stage skills. We will start off by discussing case conceptualization. Go to slide 2 in your PowerPoint. Case conceptualization is like a roadmap for working with a client. It will help you understand why a client is experiencing particular problems, organize complex clinical information into a coherent picture, and guide you in developing a treatment plan. Case conceptualization helps us understand the presenting problem. So, Corinna has depression and anxiety issues. This would be her presenting problem. That problem did not crop up sporadically without any antecedents. The case conceptualization also includes predisposing factors and precipitating factors that get at antecedents. The predisposing factors are things from her developmental history, early childhood, genetics, etc. This is information that we do not readily understand about Corinna, and we would need to get more of if we met her in person. Precipitating factors are triggers, events, or stressors that led her to her most recent episode. It very well could be the case that the recent episode of stress was so severe for Corinna that she sought out treatment. So in sum, precipitating factors and predisposing factors are important to assess when working with a client. Perpetuating factors are what maintain the problem: bad coping strategies, environmental reinforcements, etc. For Corinna, this could involve the withdrawal and clingy behavior she exhibits toward her partner. If her clingy behavior sometimes results in her getting occasional closeness with her partner, or if individuals reassuring her results in her getting temporary confidence, then this may reinforce unhealthy behaviors. The last point I want to make here is that case conceptualization often leads to a treatment plan. This is what I mean by it is a roadmap. It's a roadmap to the destination of being able to successfully treat the client. Go to slide 3. This slide contains different guidelines to keep in mind when working toward case conceptualization. Your observations in the clinical setting are important. These may involve viewing ways of communicating by the client, information that the client emphasizes, etc. As the client interacts with you, consider asking yourself how similar or different your relationship is to their outside relationships. All of the factors that we considered for forming interpretations are relevant for case conceptualizations. Go to slide 4. If the case conceptualization is the roadmap, a shared understanding, a living document that documents how the client came to be a certain way, then the treatment plan is an action plan that flows from that. It has goals, objectives, timelines, interventions, and a process of evaluation. So for Corinna, perhaps a goal of hers would be to reduce depression symptoms and alleviate anxiety. That is the overarching goals. Her objectives are the concrete, measurable steps toward each goal. So for Corinna, this may involve using 3 coping strategies: deep breathing, writing, meditation practice, to center her in situations where her partner does not directly text her back. Treatment plans also include interventions. So this is what the clinician would actively do to help Corinna meet her goals. This could look like practicing coping skills in therapy or actively processing some of Corinna's earlier childhood experiences in relationships that allows her to consciously make better decisions about her life. Treatment plans include timelines for treatment and target dates for review, and it also includes how progress will be evaluated. There needs to be some kind of standard check of progress via questionnaires, testing, observation, or discussion so that it can be determined if the client's goals are being met. Let's move to discussing the 5 stages of implementing insight stage skills. Go to slide 5. There are 5 stages I want you to keep in mind for integrating the insight stage skills. Go to slide 6. Number 1 is setting the stage. Helpers pave the way for the insight stage through empathy, reflection of feelings, and helping the clients explore. With difficult helpers, if clinicians are able to put themselves in the client's shoes and try to understand what is going on with the client, they will often be able to avoid being judgmental and will be able to forge a relationship with the client. Taking time to understand the client is important because it will help clarify what is going on with the client instead of jumping to conclusions. So spending time with Corinna to understand her feelings and experiences will be helpful. Being careful to regulate any annoyance or irritation one experiences when she is seeking reassurance will be important. Go to slide 7. Step 2 involves looking for markers of readiness for insight and conceptualizing the client along the lines of what we discussed earlier. Based on the case study, it's clear that Corinna is exhibiting markers of readiness for insight by way of her asking if she is crazy for feeling the way that she is feeling. We can also see that she is ready for insight given her extreme distress and discrepancies across her investment in the relationship and her desired outcomes from her partner. Go to slide 8. Step 3 can involve determining your intentions and engaging in an interactive, collaborative insight process. It's important in step 3 of this process for the clinician to take a stance of curiosity rather than one of showing off how much he or she knows. Back and forth verbal exchanges occur in this stage, which may lead to the client modifying interpretations and the client going back to an earlier stage of exploration. Go to slide 9. Returning to an exploration stage and following up is warranted in step 4 because rarely does a single challenge, interpretation, or moment of immediacy bring about lasting change. Oftentimes, things need to be repeated by the clinician and processed repeatedly by the client. So for Corinna, this may involve pointing out to her repeatedly the different mental loops she has when panicking about lack of communication from her partner in order to encourage her to break the cycle. Go to slide 10. Step 5 involves checking in with the client and ensuring that they are gaining insight. A clinician may think they are really resonating with the client, but then be surprised if they checked in and find out that much has not changed internally for their service recipient. Knowing where the client is can help clinicians plan for the future. And finally, navigate to slide 11. Here's a brief list of some difficulties in working through the insight stage. Most of the challenges with using the insight stage that can occur here can be remedied by keeping a keen eye for markers of readiness for insight, focusing on empathy and using exploration skills, dealing with personal feelings, and dealing with the therapeutic relationship if there are strains or if the client perceives the clinician as hurting their feelings or making a mistake.